Artificial Intelligence Doctor. Troubleshooting and Complications in Left Bundle Branch Area Pacing, LBBAP. Conduction System Pacing, CSP. Specifically, LBBAP is changing the game for ventricular pacing, moving beyond traditional RV pacing to offer better synchronization and clinical outcomes. LBBAP has shown superior outcomes to RV pacing and may even be better than traditional biventricular CRT for heart failure patients. However, the unique lead placement in the interventricular septum, IVS, presents distinct, though rare, complications and necessitates meticulous follow-up. We'll cover the essentials. Challenge 1. Inability to penetrate. This usually comes down to lead/sheath orientation, non-perpendicular, angulation causing poor torque, or being too proximal near the annulus, fibrous tissue. Tip: target where the R wave is 5 MV and you see a good myocardial injury current, IC, before fixing. Challenge 2. Perforation, critical to recognize. Watch for these simultaneous clues that the lead is passed into the LV cavity. Signs of perforation.
1.
Unipolar impedance, abrupt drop, 150-200 omega, or absolute value, less than 450 ohms.
2.
Injury current, loss of the IC as the helix hits the LV endocardium.
3.
Pacing threshold. Tip pacing has very high or no capture, but the ring electrode is still capturing the LBB. Also watch for coronary vessel injury, septal perforators, and intraseptal hematoma, which are rare but serious. Short and longer-term complications. Short-term, within 30 days, microdislodgement. This is one of the most common acute lead issues. The lead retracts slightly, losing LBB capture and only capturing the RV septum. Crucially, the only way to spot this is by comparing the follow-up 12-lead ECG morphology to the implant ECG. Delayed perforation, a rare but major risk, usually stemming from an unnoticed microperforation that progresses. If suspected, confirm with echocardiography. Management is critical. Anticoagulation and strong consideration for explantation to prevent cardioembolism. Longer-term challenge, lead extraction. While initial extractions have been encouraging, leads with longer dwell times may be more challenging, potentially requiring special tools and carrying the risk of helix fracture. Follow-up and device programming, 90 seconds. Follow-up protocol. Plan for 2 in-person checks in the first 3 months. Always perform a 12-lead ECG during threshold testing. This is your primary tool for detecting subtle microdislodgement or perforation. Programming outputs. Acute phase 0 to 3 months is typically programmed high, e.g. 3.5 V at 0.4 milliseconds. After the 3-month check, lower the output to twice the safety margin if the threshold is stable. Programming AV delays. For patients with AV block, use a shorter AV delay, e.g. PR-30 ms, to ensure LBB capture. For LBBAP CRT, program LVRV offsets to 80 milliseconds to promote pseudofusion. Programming auto capture. Inactivate automatic capture algorithms unless they have been proven accurate for that patient. They are designed for myocardial capture and may lead to either underpacing the LBB or overpacing the septum, draining the battery. Troubleshooting. T-wave oversensing, twos. LBBAP leads can sometimes oversense large T-waves, leading to double counting events. In ICD patients, this can trigger inappropriate therapy. Fixes. Increase the post-pacing ventricular refractory period or reprogram to a less sensitive R-wave setting. Conclusion. LBBAP, left bundle branch area pacing, is a powerful therapy, but successful long-term management requires diligence, detailed ECG follow-up, and careful, individualized device programming.